Bismillahirrahmanirrahim. In this video, we are going to talk about medical anesthesia techniques. First of all, we are going to discuss the applied anatomy, then the medical anesthesia techniques, and finally, we are going to discuss some pitfalls during medical anesthesia techniques. In this slide, you can see the transfer anatomy related to the inferior alveolar block. As we go from the outside to inside, we can see masseter muscle, ramessor mandible. Here, this is the pterygomandibular space, then the middle pterygoid muscle, and the superior constrictor of pharynx. As we go from interior to the posterior part, you can see the buccinator muscle, the ramus, the lingual nerve, the inferior alveolar nerve, the neurovascular bundle, and at the depth, you can see the throatic gland. You can see the relationship of lingual nerve with the inferior alveolar nerve. Inferior alveolar nerve lies at a deeper level at the depth of 25 mm, and lingual nerve lies at in a superficial location just deep to the buccinator muscle. So, as we are going to move this needle, it will pass through the buccal mucosa, then buccinator muscle, and enter into the pterygomandibular space at the depth. First, we hit the bone at 25 mm, and you anesthetize the inferior alveolar nerve. As you come back, you give 0.2 ml of the solution just deep to the buccinator muscle, and here, hence, the lingual nerve get anesthetized. In this slide, you can see the relationship of inferior nerve with the lingual nerve, and also you can see the buccal nerve, which is supplying the buccal mucosa. The inferior alveolar nerve lies at a deeper level, and the lingual nerve lies superficially just deep to the buccinator muscle. The long buccal nerve can be anesthetized just in front of the external oblique ridge. And interiorly, you can see the mental nerve. This is the terminal part of the inferior alveolar nerve. It is going to supply the labial gingiva and the lip. Now we are going to discuss the advantages of inferior alveolar nerve. The first of all is the inferior alveolar nerve block is acceptable to practitioners. It has faster onset than higher blocks, just such as the Gauguin block, and it relies on the bony landmark, not on the soft tissue landmarks. The disadvantages are that it's in the area is highly vascular, and so there is 10 to 15% chances of positive aspiration, unlikely to anesthetize the accessory nerves, and unlikely to anesthetize the long buccal. And finally, in some patients, it's difficult to see the landmarks, such as the patient with microclasia, and the patient who have thick cheeks. Inferior alveolar nerve block has spinal landmarks. The coronoid notch, this is the greater depression in the anterior border of mandible, and also called the external oblique ridge. Then the internal oblique ridge. Then the pterygomandibular raphe. This raphe is present between the buccinator and the superior constrictor of pharynx. Then the pterygotemporal depression, and finally the contralateral mandibular bicuspids. So when giving inferior alveolar nerve block, you have to first see the landmarks. In this diagram, you can see two lines. One is along the external oblique ridge, and it's located on the left side, and the other is the pterygomandibular raphe, which is located on the right side. And you can see a depression between these two, and the needle is penetrating through that area and then travel further to the inferior alveolar nerve. Here you can see the mandible from the lateral aspect. Interiorly, you can see the mandible foramen, and then you can see the external oblique ridge. As it goes up, you can see the coronoid notch. This is one of the landmarks inferior alveolar nerve. and going beyond that region you can see the coronoid process. This is not related in the inferior alveolar block. Now in this slide you can see the mesial aspect of the mandible, and the ramus is visible. You can see the mandibular foramen through which the inferior alveolar pass. Then you can see the coronoid process, and then adjacent to the index finger you can see the coronoid notch, and also you can also see the dental syringe coming from the contralateral side and reaching up to the mandibular foramen. Here you can see the landmark for inferior alveolar block in a patient. The coronoid notch, the greatest depression on the interior part of the ramus, is called the external oblique ridge, and the operator finger is on that area. The internal oblique ridge can be palpated. Then on the mesial aspect you can see a dotted line. This is the pterygomandibular raphe, and in between these two areas this is the pterygotemporal depression, and the other one is the contralateral mandibular bicuspid, but it's not shown here. So before you start, you apply the topical anesthetic. Before giving inferior alveolar block, you palpate the landmarks. You start from the external oblique ridge and going inside or in the medial aspect. Then you feel the pterygotemporal depression. Here you can see the pterygomandibular raphe, and just the side areas just lateral to it is the pterygotemporal depressions. Again, this slide is repeated just to emphasize where you are going to penetrate your needle. This is the target area. When you give penetrate up to the depth of 25 mm. This is not the exact value, it can be a range. So depending upon a younger patient or an adult patient, you can vary the depth of needle insertion. And as you come out, you give at the depth of 5 mm, you inject again to anesthetize the lingual nerve. This is the transfer section. The needle is coming, and it has passed through the buccal mucosa and then penetrating through the buccinator muscle and entering into the pterygomandibular space and reaching up to the mandibular foramen. And here you are going to inject for inferior alveolar. Before you insert your needle for inferior alveolar block, you approximate the height, and is at the level of middle of the palpating fingernail or the thumbnail. Then insert the needle into the pterygotemporal depression. Then ensure that the barrel of syringe is located over the contralateral bicuspids. Insert until bone is contacted. Then withdraw for 1 mm. The depth of insertion for average size adult is approximately 25 mm. Then aspirate in 2 plane and then inject the full cartridge. The onset of and duration of local anesthesia. The onset of hard tissue anesthesia is 2 to 4 minutes. Duration of hard tissue anesthesia is 40 minutes to 4 hours, depending on the type of local anesthetic use and whether a vasoconstrictor is used. It is unlikely that the long buccal nerve will be anesthetized. So you are going to anesthetize the long buccal nerve by long buccal nerve block on external oblique ridge, slightly higher than the inferior alveolar block. You are going to inject 0.2 mm, and hence the long buccal nerve will be blocked, and it is going to anesthetize the buccal buccal mucosa, buccal gingiva up to the second premolar. And here we are going to come to the end of this video. Hope you have learned about inferior alveolar block. Thank you very much for watching. The LS syringe and with cartridge and needle is ready for local anesthesia administration. The needle has been inserted into pterygotemporal depression. Aspiration is being done. The aspiration is negative. And now local anesthesia is being injected. Now long buccal anesthesia is being injected.